Chronic lymphocytic leukemia. Etiology and pathophysiology. The cause of chronic lymphocytic leukemia, CLL, is unknown. There is evidence of a familial tendency, which shows the phenomenon of anticipation, i.e. CLL occurs at an ever earlier age in succeeding generations. CLL is a disease of deregulated programmed cell death, apoptosis. CLL cells accumulate because they survive for an abnormally long time, not because they divide at an accelerated rate. Epidemiology. CLL accounts for about 25% of all leukemias. It is most common in the elderly, with an incidence close to 50 per 100,000 individuals after the age of 70. It is extremely rare under the age of 30. It is twice as common in males. In the Far East, and in Japanese immigrants to America, the disease is less common than in whites and Africans. Clinical presentation. NB. Currently, the vast majority of patients with CLL will be diagnosed while being investigated for another reason. A large proportion of these will never require treatment. It is important to remember, however, that leukemia is a frightening diagnosis. Ensure that someone with experience in this disease can discuss it with the patient. Up to 80% of patients will be diagnosed following the finding of a lymphocytosis in the course of investigations for another reason, e.g. preoperative assessment. The features of disease are discussed below. Common. Symmetrical lymphadenopathy. Splenomegaly, 50% of cases. Recurrent and severe infections, due to hypogammaglobulinemia. Anemia. Less common. Hepatomegaly. Constitutional symptoms, sweating, fevers and weight loss. Bone marrow failure, thrombocytopenia and anemia. Investigations. Lymphocytic infiltration of the peripheral blood. The cells are mature and uniform in appearance. Smear cells are seen, Fig 27. Lymphocytic infiltration of the bone marrow. Atropine may be helpful to indicate the pattern of involvement. Immunophenotyping of the cells will confirm the diagnosis. Cells are characteristically positive for CD5 and CD23, negative for FMC7, with weak expression of CD22 and surface immunoglobulin. Anemia and thrombocytopenia may be present, due to either bone marrow failure or autoimmune causes. Direct antiglobulin test is positive in autoimmune hemolytic anemia. 10% of CLL is detected this way. Hypogammaglobulinemia tends to be common in advanced cases of the disease. Chromosomal abnormalities are found in at least 50% of patients. Staging. See Table 16. Treatment. The indications for active treatment depend on the stage and activity of the disease, bulky or rapidly progressive disease, or disabling systemic symptoms. There is no evidence that earlier treatment of asymptomatic or early-stage disease is beneficial. The treatment options in stage B or C disease include the following. Corticosteroids. These are particularly helpful in the early treatment of patients and in those who have autoimmune phenomena. Chlorambucil. This can be given continuously or as monthly courses. Other types of chemotherapy have been tried alone and in combination. Fludarabine has given promising results, especially in combination with cyclophosphamide. Monoclonal antibodies are increasingly used, particularly rituximab, anti-CD20, and alemtuzumab, anti-CD52. Splenectomy. This can be of use to debulk disease as well as to treat refractory immune cytopenias. Remember that in this situation vaccination may not be effective, as antibody formation is greatly reduced. It is therefore important to maintain these patients on prophylactic penicillin, or erythromycin if allergic. Transplantation, autologous and allogeneic, is useful in selected younger cases. Prompt antibiotic therapy for infections. Consideration of prophylactic infusions of intravenous immunoglobulin in patients who have recurrent troublesome infections. Avoiding and treating the side effects of steroids with antifungals and histamine H2 blockers. Complications. In a small proportion of patients with CLL, the disease may transform to a more aggressive type. This may manifest as refractoriness to treatment, systemic symptoms, increase in disease bulk, and a change in the morphological features. Prognosis. The stage is important in determining prognosis in CLL. Other adverse factors include atypical lymphocyte morphology, lymphocyte doubling time less than 12 months, bone marrow trephine showing diffuse involvement, certain chromosomal abnormalities. Stage B and C. Males. High expression of CD38. Unmutated immunoglobulin VH gene status. The median survival in all patients with CLL is 10 years. Patients who have early-stage disease have at least a 30% chance of dying due to an unrelated cause. Death due to CLL is usually as a result of infection or bone marrow failure.